Okay, welcome to Strengthening Identity, Addressing Internalized Stigma in Mental Health Recovery. This is our January session of the Cultural Responsiveness Learning Community. This learning community meets every Tuesday from 3 p.m. to 4:30 p.m., where we talk about emerging relevant topics to FCS service provision in the context of cultural responsiveness. Today, we're going to be focusing on this piece about disability, particularly disability identity and mental health disability identity. I want to thank everyone for coming today. Today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This will be an interactive training, and we certainly encourage you to engage and participate in breakout sessions, activities, discussions, using your chat feature, using your microphone, whatever feels good and right for you. The slides, as well as a link to the recording of the webinar, will be provided after the webinar. The recording will be posted to the DBHR Washington State Healthcare Authority YouTube page. And I will actually put these slides into the chat at the end of today's session. So you'll receive all the materials in the chat for download immediately at the end of today's session. Please note that the use of automated note-taking bots, similar tools during Washington State FCS events or meetings requires prior approval. Unauthorized use of such tools is prohibited to ensure the privacy and confidentiality of attendees for today. Any recording that is created through AI is not recognized as an official recording of this session, and FCS, the DBHR Healthcare Authority reserves the right to exit trainees from the training if they are using AI to take notes without prior approval or using AI to record the session. And just again, materials are no longer emailed to participants. Materials will be uploaded to the chat, and the recording will be available on the HCA FCS channel for your use and resources. Again, it's that FCS YouTube channel listed in the PowerPoint slide that is hyperlinked. Gentle reminder for folks. I'm hearing a little bit of feedback. If you could, please make sure your microphone is muted. And that way we can reduce some of that feedback. Thank you. Gentle reminder for folks joining the cultural responsive learning community, we like to operate with some basic guidelines in terms of how we interact in this virtual space. I believe in co-learning. Everyone here has expertise, competencies, knowledge, lived experience. And so we leverage each and everyone's participants' knowledge, competencies, lived experience to support co-learning. We look at this space as a safe space where everyone is able to share and learn and ask questions while simultaneously maintaining respect for the complex and beautiful identities that we all bring into this virtual space. Please be present and lead with curiosity. And again, this is a stigma-free zone. So for today, we are going to be looking at this topic, right, of internal stigma, which is going to be within the context of mental health conditions and how that is relevant to identity development, recovery, and what we can do as practitioners to support people in attenuating, mitigating, right, negative illness identity, internal stigma, right, that transitions to a negative illness identity and or sick role. So for today, we're looking at defining key concepts, looking at stigma, illness, identity, models of disability. We're going to look at some historical models of disability and how they may have inadvertently contributed to stigma associated with mental health conditions, how they may have infiltrated our nomenclature, our verbiage, and how that may come out potentially in stigmatizing bias or prejudicial ways. And we're going to review strategies to counteract internalized stigma, to promote strength-based identity in our professional practice and our interactions. So I see some things coming into the chat. Okay, some folks introducing themselves. Thank you so much. Welcome, welcome. Great to have you here. So we're seeing that this is a part of our cultural responsiveness series. And when we think about that term cultural responsiveness, ultimately it just involves understanding and meaningfully and appropriately including or responding to cultural variables, right? And the full range of cultural identities or dimensions, diversity that individuals may come to services identifying with, right? Or communities they are a part of. Cultural responsiveness requires valuing diversity and different identities, being aware of cultural facets, right? Seeking to further our cultural knowledge, working towards, the creation of community and or organizational competencies, organizational values, where diversity, inclusion is incorporated into not just service provision and service conceptualization, but interactions and the organization's policies, mission, etc. Right? That's all part of building a cultural responsive service system from down to the individual staff or practitioner up to administration, the organization, and institutional level. When we think about cultural facets, cultural identity is complex, multifaceted. Oh, am I missing something? Oh, did someone have a question? I think that might have just been feedback. So when we think about cultural identity, it's a complex and a driving force behind who we are, how we move throughout the world. And it's shaped by many factors or variables, including race, class, gender identity, affectional identity, um, right? Religion, linguistics, right? All of these things are part of cultural identity. And when we think about these cultural facets, there's this piece of intersectionality. This is a term that was coined by Kimberly Crenshaw, and it refers to the interconnected nature of these social or identity categorizations, which are overlapping and can be interdependent systems where we experience either points of privilege and or points of oppression or an absence of that privilege. In the context of today's discussion, right, disability and mental health, right, mental health conditions or mental psychiatric disabilities, intersectionality can help us to understand how individuals with various disabilities, right, mental health conditions, psychiatric disabilities may experience a compounding of barriers based on multiple aspects of identity, right? So these cultural facets are interconnected and can mitigate and or exacerbate points of privilege, right, or disability identity. So take a moment to reflect on your facets of your identity, right? What cultural facets come to mind for you in terms of your own cultural background? How do these aspects um, impact or intersect, right? How do these cultural facets intersect? How do they influence your experience of living in this country, in the United States? How do they impact your experience living in Washington State? Or how have these cultural facets impacted your education, employment, the services that you provide. Does anything come to mind as you think about your own cultural facets? You can put in the chat. Anything come to mind as you reflect on your own culture? Maybe one category is more present than another, right? Do you see some things? Bell Hooks was talking about it in the mid 90s, didn't call it intersectionality though. Yeah, yes. This has been a discussion that has certainly been part of conversations um, throughout our field, various fields, um, in literature, in terms of, right, how culture is made up or comprised of different facets and how they kind of interact. Thank you. So, going into today's topic a little bit deeper, right? We're focused on this piece about disability identity. Um, when we think about disability in the United States, over 60 million Americans identify as living with a disability. And that makes people with disabilities the largest minority group in our country. That was from the Center for Disease Control, the CDC, in 2023. Interestingly enough, this is one of the minority groups that anybody at any point in time can join because we have acquired disabilities, right? Where people may, throughout their lifespan, develop a condition that could meet criteria for having a disability. When you hear that number, 60 million, right? 60 million Americans living with a disability. Is that larger or smaller than you expected? You could put that in the chat. You could put a S for smaller, L for larger. What do you think smaller? Larger. Yeah. Okay, so I'm seeing a lot of largers coming in. Yeah. When we think about specific to mental health conditions, right, psychiatric disabilities, according to the National Institute of Mental Health, approximately 23% of Americans, adults, experience a diagnosable mental health condition. So roughly 1 in 4 adults may be diagnosed and living with a mental health condition. And we know that there are certain laws, certain pieces of legislation that exist, the Americans with Disability Act being one of them, that gives definition to what disability is and provides legal civil rights, right? Legal protections and civil rights for people with disabilities. The ADA defines a person with a disability as an individual who has a physical or mental impairment that substantially limits one or more major life activities or life domains. And that would be living, learning, working, and social, right? So these could include activities such as breathing, walking, talking, hearing, seeing, um, doing activities of daily living, working, going to school, right? Doing, manual tasks. In 2025, we actually celebrated, we marked the 35th anniversary of the ADA, which again is that landmark piece of legislation that granted civil rights and protections to people with disabilities. With that in mind, take a moment to consider, right? Just because that law exists, does that mean that equity has been achieved? What do we think? Put a Y for yes in the chat. We're achieved. Great. Mission accomplished. Or N for no. Equity has not been achieved yet for people living with disabilities. Let's see. Yeah, I'm seeing no's, some very loud no's in the chat. Yeah, absolutely. Despite having legal protections, institutional ableism, inequity continues to persist. Where does it persist? Well, just about anywhere, right? Higher education, employment, counseling practices, housing, public life. People with disabilities still face significant barriers, including lack of physical and programmatic access, right? Especially in healthcare, in mental health services. There's social stigma, inadequate funding for services and support programs. We know research from both US and globally, right? It shows that people with disabilities, including psychiatric disabilities, experience significant inequity in health outcomes and access to care, right? So we see that people with disabilities have higher rates of poor health, reduced access to service, higher morbidity, mortality rates than non-disabled population. And these disparities can be attributed to structural and systemic barriers, right? Not simply by a person's diagnosis or condition. We see that adults with disabilities report frequent or higher rates of mental health concerns, highlighting a connection between disability, mental health, and overall well-being. So when we think about that, right, we think about this presence of inequity and drivers of that inequity. And oftentimes, one thing that is cited is stigma. So let's take a moment and refine our collective understanding and working definition of stigma. Right? We want to be using our verbiage in a concise way, an accurate manner. So I'm going to put you into small breakout group rooms, and in your rooms, just discuss your understanding of stigma. Right? What does stigma mean? What does it entail? And be prepared when we come back in to put in the chat what you guys came up with. Right? So you're just going to chat with your virtual colleagues about what stigma is, right? How do you define it? Maybe how do you see it in your practice, right? And we'll give about like 5 minutes for folks to chat. If you are in your breakout group room and no one has joined your session, I will try and move you to another room with participants in it. I always like check on that, so please be patient. Let me know if you have any difficulties getting into your room, and we'll see you back in like 3 to 5 minutes. I'll also share this slide to the breakout group room so that you guys can remember the prompt. All right. We're going to pause recording and we'll put that back on after we've debriefed our activity. Resume recording. So you guys, again, spot on. Stigma refers to negative set of beliefs, attitudes that society or individuals hold, particularly about characteristics, attributes, right? Conditions, right? In the context of mental health, stigma involves negative stereotypes, misconceptions about mental health condition that result in individuals, and someone mentioned this, being marginalized, right? Isolated, devalued, treated unfairly. According to SAMHSA, Substance Abuse and Mental Health Service Administration, stigma is when someone, even yourself, views a person in a negative way because they have a mental health condition.
Control.
Stigma can, Christy, yes. Oh, did you want to share?
Sorry, didn't know my microphone was on. I was talking to my cat. Sorry.
I have 6 and I talk to them frequently, so no worries. I get it.
She's elderly and kind of maybe getting senile. So yeah, she does
No
weird
worries.
behaviors. So sorry.
No worries. So when we think about stigma and the forms of stigma, it can take form of public stigma, right? General public in terms of discriminating attitudes towards people with mental health conditions. There's self-stigma, right? And we're talking about that a lot today. Internalization of those public views, those societal views, right? When that person hears what the message is and then applies it to themselves, impacting identity. And that's a dangerous place to be in, right? In terms of that diminished sense of self-worth, identity, capacity, self-efficacy, right? All of those things can be impacted. And then there's that structural stigma, which someone mentioned, right? The institutional policies, practices, that could restrict opportunities and rights of individuals, right? And in this context, um, individuals with mental health conditions. When we think about stigma, there can be various, um, oh, Gloria, I hear you, and I don't know if you want us to hear you. I'm going to mute you. Again, kindly, if you do have a mic on, please take that opportunity to go ahead and hit that mute button. And when you want to share, please feel free to unmute and share. That's certainly encouraged. But when we think about components of stigma, we can think about stereotypes, right? That's oversimplified, fixed ideas about a group of people. And stereotypes can lead to or are generalizations or inaccurate assumptions about individuals belonging to a group, right? There's prejudices or preconceived notions, opinions, judgments, feelings that are often negative, directed towards individuals based on group membership, like people with mental health conditions or disabilities. And then someone mentioned discrimination, and that is a behavior that results from prejudicial attitudes, stereotypes, and it involves treating people unfairly, unjustly, based on their membership in a cultural group, and in this context, individuals with mental health conditions. And so when we see these things, right, stigma, right, those negative perceptions, negative beliefs in the context of disability, that's referred to as ableism. Ableism, again, is a system of beliefs, practices, institutional structures that devalue, marginalize, discriminate against people with physical, intellectual, developmental, or psychiatric disabilities. And at its core, ableism rests on the assumptions that people with disabilities are inherently deficient, right? And need to be fixed, cured, normalized, managed in order to be valued. Disability scholars note that ableism positions disability as an individual problem rather than recognizing it's a product of social, cultural, or environmental barriers. Ableism is deeply embedded in the US culture, in our societal perception and institutions. It shapes how disability is defined, how people with disabilities are treated, and whose voices are considered to be legitimate, right? These beliefs influence education systems, healthcare practices, policies, employment policies, housing policies, service provision, and can often result in people with disabilities being excluded from the decision-making process that directly impacts their lives. That's why when we hear about disability justice and
Hey, look at
uh,
you.
hello, oh, I'm just going to mute that because I don't think we were supposed to hear that either. Um, but we were again thinking about right this aspect of nothing about us without us, which is this advocacy rallying call that people within the disability community need to be centered, right, and heard and incorporated into any room, committee, institution that is making policies, developing procedures, um, creating programs, service structures that impact their community, right? So when you hear the word ableism, what comes to mind for you? You could put in the chat. When you hear ableism, what comes to mind for you? Anything in particular that comes to mind for you when you hear the word ableism? Oh, I see some things coming in. Prevent people from growing or seeking support based on things they heard. Someone asked, yes, you will be able to get the slides at the end. Expectations. Figure it out. This isn't my responsibility. Assumptions that are limits. Yeah, you guys are spot on, right? Lack of knowledge, not understanding, not knowing, thinking people can just figure it out, but you don't look sick, right? As if disability is always apparent, is always visible, right? Christy, what is normal, right? This concept of normalization, both over and underestimating folks and their abilities, refusing to understand the concept that people's abilities change from day to day. I love that. Yes, right. I love that concept of the spoon theory, which is this notion within the disability community that every day everyone gets a unit of spoons, and each spoon represents a unit of energy, right? And doing a task may require a certain amount of spoons. And once we are out of spoons for the day, right, then we're trying to figure out what tasks do we then give up, right? So if it takes 5 spoons to go to work, if it takes 3 spoons to make dinner, if it takes 2 spoons to shower, right, and we're out of spoons, then what are we doing, right? Energy, units of energy, our abilities can wax and wane. Love that. Mobility limitations, mainstream to cultural irrelevance, spawned from eugenics. Yes, and ugly aspects of history. We're going to talk about that in just a few moments. Fat shaming is, yes. When we think about disability, think about this concept of discrimination, stigma. It goes to body shaming as well. Absolutely. Assuming someone who is disabled is less than others. Absolutely. All of these things, I think, are very accurate and based on able privilege, right? Which is also referred to as ability privilege. And that really is describing the unearned advantages experienced by people without disabilities, right? People who are considered normal, right, within the dominant social standards. And so disability theorists emphasize that able privilege operates invisibly. Those who benefit from it are often unaware of the ways that environments, policies, expectations are designed with them in mind, right? Examples of able privilege can include expecting public spaces, classrooms, workplaces to be accessible by default. Someone mentioned earlier the elevators don't work, right? People who have able privilege might not even realize when the elevators don't work. What does that mean for someone with a disability who cannot use the stairs, right? Assuming productivity, independence, or emotional regulation look the same for everyone. Um, able privilege looks like treating accommodations as special treatment rather than a civil right, or pathologizing, disabilities, right? Why valuing endurance over work, right? Emotional suppression. Able privilege really reinforces stigma by framing disability as a deviation rather than diversity. And this can lead, especially in the context of people with mental health conditions, to be minimized, misunderstood, treated, primarily through control, compliance, then autonomy, recovery, self-determination, and support. And so when we think about these factors, right, these concepts of stigma and ableism, it's important to know like what is building these attitudes and beliefs, right? What factors contribute to disability stigma? So we think about attitudes and policies surrounding the disability experience in the United States really have historically shaped, um, right, some of these pieces of stigma and ableism. The pervasive nature of mental health stigma in our society is, I think, significantly exacerbated by its representation in social media, traditional media, pop culture, like movies, television, right? These platforms not only reflect, but also can perpetuate harmful stereotypes and prejudices that contribute to marginalization of individuals with psychiatric disabilities. What are some other sources of disability stigma? Right, put that in the chat. What are some other sources of disability stigma? What comes up for folks? Anything that is really apparent. Sources, factors contributing to disability stigma. Let's see. Yeah, Serene. I think you said, oh, the belief that folks with disabilities somehow must have done something to earn, deserve their disability. We're going to talk about that on our next slide. Absolutely. Yep. Um, Systemic, poor city planning. Yes, Victoria. Um, Resources for housing, cultural. That, yes, yes, Jacob. It can certainly be coming from cultural beliefs. We also see historical misconceptions and treatment, right? Historically, mental health conditions were often misunderstood, associated with, supernatural forces, moral failings, divine punishment, right? Treatments were often inhumane, and in response to, the perception that this is a punishment or it's warranted in some capacity. Cultural beliefs and norms, right? In some cultures, mental health issues are seen as taboo, um, leading to secrecy, denial, right? Cultural norms that may prioritize physical health and productivity over mental health and mental health well-being can contribute to some of those stigmatizing attitudes. We already noted media representation. Ooh, I see some more things coming in the chat. Um, Speed of work, capitalist structure. Yes, capitalist structure where there is a emphasis on productivity. Lack of insurance coverage equals not really a problem. Okay, I'm seeing quite a bit of things. Right, so we see that this is a multi-factored issue with a lot of different pieces, um, or variables contributing from media representation, lack of education awareness, um, our healthcare system, right? The structure of our healthcare system, right? Often prioritizing physical health over mental health, leading to disparities or to negative perceptions. Um, Even societal attitudes, individualism and self-reliance, right? Emphasizing individualism, like get over it, like you shouldn't have to need help or um, right, it's mental health conditions are really not an issue or concern, right? It's not a health issue. And then we have this piece of the models of disability. Um, Really how our fields have historically theorized or conceptualized the model of disability. And that can be certainly a contributing factor to disability stigma. So, what do I mean by that? When we think about how society, through the ages, have conceptualized disability, we have first had this piece of the moral model of disability. This is one of the oldest perspectives on disability, and can be deeply rooted in historical framework as well as cultural beliefs. And within this model, disability is viewed through the lens of morality, right? Associating it as a sin, moral failing, divine punishment, um, right? It interprets disability as a reflection of an individual, right, or their family, whether there are, ethical or spiritual misdoings, right? The moral model of disability has been prevalent in many societies, influencing how individuals with disabilities are perceived and how they're treated, right? In various cultures, in religious contexts, disability has been seen as a form of divine retribution, um, so either by themselves or even by, ancestors. And this perspective often leads to stigmatization, ostracization of the individual with the disability. Then moving into like the early 1900s, we have the medical model of disability, which views disability primarily as a problem of the individual that requires medical treatment, which profoundly influenced public stigma surrounding mental health conditions. Again, this model emerged predominantly in the 19th and 20th centuries, and it frames mental health conditions as a pathology, a deficit within the individual that must be diagnosed, treated, cured by the experts. right? The medical professionals. And this perspective has contributed to significant advances in medical science, some would argue. It has also perpetuated a view of mental health conditions as abnormalities, right? Deficits that needed to be corrected, fostering a lot of societal stigma, right? Historically, this medical model has reinforced negative stereotypes, misconceptions about mental health. Um, and the medical model really emphasizes professional diagnosis, this concept of the provider being the expert, an overemphasis on the diagnosis, but also symptomology, and a creation of power imbalance between the healthcare provider, the practitioner, and the individual. Um, this dynamic was often noted as leading to potentially dependency on medical authority, where individuals were seen as passive recipients of care rather than active agents in their own treatment and recovery. And really, that framework can diminish an individual's autonomy, self efficacy. But again, it's going to perpetuate these societal attitudes um, where mental health conditions are being stigmatized and require control and supervision and oversight by experts. So you can see how this would then result in those societal perceptions that individuals with mental health conditions might be incapable of making decisions for themselves, right? For further stigmatizing individuals, right? Folks with mental health conditions. And this medical model definitely impacted institutional policies, societal norms, structural stigma, right? Which included discriminatory practices embedded in laws, policies, institutional behaviors, which was often justified by this like perspective of the medical model. So thinking about that, any thoughts you could put in the chat? Do you see any relics of the medical model in your organizations or in the work that you've done, maybe historically or currently? Put a Y for yes. Any medical model relics, right? That emphasis on treatment compliance, hierarchical treatment, overemphasis on pathologizing. I remember working in supported housing, and there would be folks that would have significant others, right? They would have significant others, and they would um, be dating, and oftentimes that relationship was viewed as pathology. It was pathologized, not a normative part of being 20 and wanting to date. It was viewed as, well, this is symptom and symptom related. That would be like a medical model relic. See some things come in the chat. What do we got? Must provide a diagnosis to be eligible for Medicaid. Yeah, so that can come down to, right, how are we walking this line of medical model versus the other models um, when we are looking at funder requirements. Yeah, not at work, but in both my sons, my daily life with both of us being disabled, we deal with stigma daily. Yeah, it can be ever present. Um, a lot of proof of how sick you are, Victoria, embedded in assessments, for example. Yeah, and that goes back to this piece about like funder requirements, right? Where they want to determine the existence of a disability. And so there's always this emphasis on diagnosis, assessment, functional assessment, right? Which doesn't always feel very strength-based, very person-centered, very recovery-oriented. And so it's like we have to like merge these two demands, right? Um, that can be such a challenge. But when we think about, the impact of this moral and medical model, um, it was almost a means, right, of conveying and sustaining otherness, conveying and sustaining otherness. Simone de Beauvoir, a prominent existentialist, introduced this concept of otherness in her seminal work, The Second Sex. The Second Sex. Otherness refers to a process by which a dominant group defines and marginalizes a subordinate group. by perceiving them as fundamentally different and inferior. And this dynamic is kind of central to understanding societal hierarchies, power relationships, privilege versus power. And it's relevant to our discussion of disability, particularly in how society perceives and treats individuals with disabilities, right? That framework of otherness helps explain the marginalization and stigmatization that people with disabilities often face, which someone mentioned can lead to, right, social exclusion, right? Society often defines individuals with disabilities as others, viewing them as different outside the norm, right? And this process of othering reinforces that social exclusion and segregation. Other components of otherness, perspectives of otherness. People with disabilities are objectified, often seen as not whole individuals, but as objects of pity, maybe inspiration or charity, right? This objectification can lead to treating individuals with disabilities as less than fully human, focusing on their disability rather than their abilities and individual um, strengths and characteristics. We also see this piece or perspective associated with otherness. And when we talk about otherness, insert any marginalized group within this context and conversation. This can be anyone deviating from, deviating from the dominant group. So this could be people with disabilities. This could be people of color. This could be, women and individuals who identify as women, right? Um, so we see different and separate. People with disabilities are often viewed as fundamentally different from individuals without disabilities and are frequently, um, you know, segregated, right? Even um, contextually segregated or conceptually segregated. Simplification, right? That the diverse experiences and capabilities of people with disabilities are often oversimplified into stereotypes. And these stereotypes will always fail to capture the full spectrum of people within the marginalized identity, right? In this context, reducing their identities to their disability alone. This piece of unchanging. People with disabilities can be perceived as unchanging with their identities, seen as fixed, limited, right? And this perception denies that person potential for growth, development, change, locking them into a static role or expectations. Um, and passivity, which can go hand in hand with that objectification. People with disabilities are seen as passive, dependent, in need of care, rather than as active, capable agents making their own decisions. Um, oh, I hear someone. Did did someone want to share? Oh, maybe that is not meant for us, so I'm going to mute that. Okay, I'm seeing some things in the chat. At a job a few years ago, we worked with people with developmental disabilities, and when they wanted a boyfriend, girlfriend, they would say it was their. Oh, I can't scroll down any further. Hmm? Oh, where did that comment go? I am so sorry. My computer pad is sticking. They would say it was their disability. Yeah, pathologizing and normative. Everyone wants to experience having friends, partners, relationships. Um, that is not something based in pathology, right? And so that's a great example of, unfortunately, that medical model in practice, right? Emerging challenge, different levels of access based on disability, where customer who have an easier time accessing our resources are more likely to get access to them, whereas folks who face greatest barriers are not able to connect to resources. Yes. So going back, Kendra, to that inequity in access, that when we design a service system, it's very important that people who are going to be utilizing that service system are a part of that conceptualization and development because they would be able to understand the barriers very intimately, to speak to them, to present them so that they will get addressed systemically. right, in a systematic manner. Um, right, when we think about including people, right, within service utilizers, people within service as a part of um, the development of program design, service design, even our satisfaction surveys will tell us, right, where those barriers lie. And so it's so incredibly important to give people that voice. So when we think about, right, this, these models of disability, ultimately what we're alluding to is that the system um, and vis-a-vis the provider, the staff, right, can be impactful in terms of disability stigma, right? That the service system, the framework that the service system was designed under, that medical model, um, as well as we mentioned those funder requirements, and then funneling down to the practitioner can directly impact disability stigma. That may be disheartening to hear, but it's also hopeful to note that if we know the system is having an impact, if we know providers are having an impact, well, we can do something about that. If we understand it, if we know it, then we can fix it, right? We have a direct impact about our own attitudes, our own belief system. We can influence our work culture. We can hopefully influence um, our colleagues. If we're supervisors, we can influence our department, our program. If we're administrators and leadership, hopefully we can influence our organization. So when we think about provider attitudes, what evidence do we have? In 2018, there was an article published um, that perceived provider stigma as a predictor of mental health service utilizers' internalized stigma and disempowerment. This study explored how perceived stigma from mental health providers affected internal stigma and disempowerment. And it found that stigma from providers, characterized by either negative attitudes or social distancing, right, was linked to higher rates of internalized stigma, reduced self-worth, and disempowerment in users, those service users. And this stigma undermines that therapeutic relationships um, impact recovery efforts, right? That how we operate, the attitudes that we endorse, the way that we connect with people impacts someone's recovery trajectory, right? This study involved 350 participants. I think this was done in Connecticut, and it confirmed that when people perceive negative attitudes, reactions, social distancing, provider attitudes, right, they contribute to a higher rate of internalized stigma and disempowerment. We also see in qualitative research on the experience of mental health service users that clearly indicated, right, stigmatizing attitudes and behaviors from professionals as well, being an important concern in the development of internalized stigma. And this was done by Dr. Charles and colleagues. And that article was Mental Health Provider-Based Stigma, Understanding the Experience of Individuals, and they also looked at families, individuals and families. And this was an ethnographic qualitative study on the personal account of mental health service users and families on stigma within mental health service settings. And they found that stigma within setting was characterized by blame and shame, disinterest, dehumanization, poor prognosis, and this piece of coercion. Right. So there is evidence to suggest that if this service system has a framework that is stigmatizing and providers have attitudes that are stigmatizing, we are then impacting the prevalence of internalized stigma. And again, that's self-stigma, and it occurs when individuals with mental health conditions internalize negative stereotypes and prejudices. We know that there are 3 stages for someone developing self-stigma. This was actually developed by Dr. Patrick Corrigan, who unfortunately passed away recently, but he is a leading expert or was a leading expert in self-stigma, internalized stigma. and disability identity. And his three stages of developing self-stigma or internalized stigma came down to the three A's: awareness, agreement, and application. And so I really want you to think about the people that you provide service to and be mindful. Are you seeing these three A's? If you are, that means that that person may be at a higher rate of experiencing internalized stigma. Those three A's, again, awareness, right? That stage involves an individual recognizing societal stereotypes about mental illness, right? So a person may be aware that there is a stereotype that individuals with mental illness are incompetent, right? So that's awareness. Two is agreement. In this stage, the individual starts to agree with the societal stereotype they become aware of. So, for instance, a person might believe, yes, people with mental health conditions, they are incompetent. And then there's the third part of this process, and that's application. That final stage involves the individual saying, I am aware of it, I'm in agreement with it, and now I'm going to apply it to myself. Right. So that last stage is because I have a mental health condition, I am incompetent. And the progression through these stages result in significant impact on the person: decreased self-esteem, decreased self-efficacy, and that goes further, right? It's not just a person experiencing low self-efficacy or low identity or self-worth. It impacts person's functional outcomes, right? It can impact how they engage in some core social determinants of health, like work and school, right? I chose work and school to highlight because every other social determinant of health, healthcare, the community a person resides in, right? The food that they have access to, what food they can buy with the money that they have, um, the neighborhood that they reside in, the housing that they have, all of those things are impacted by education and employment. And we know that internalized stigma impacts both of these roles, student and worker, right? Internalized stigma can be seen impacting self-efficacy with employment and their ability to succeed in the workplace, right? That diminished self-efficacy can deter individuals from seeking job opportunities or advancing in their careers, or could have avoidance behavior, right? Fear of being stigmatized, discriminated against can lead to individuals avoiding disclosure of their mental health status, seeking accommodations, or applying for jobs. It can be correlated with lower job performance, right? That stress and anxiety with internalized stigma can impact a person's executive functioning, concentration, right? Decision making, overall job performance, could limit their career aspirations or goals, right? Um, Impact on education could certainly impact a person's academic self-esteem. There could be school avoidance or dropout, right? Decreased engagement in the academic role, impaired concentration or learning again, reluctance to seek support, right? Diminished um, help seeking behavior. And it can also ultimately, when a person is internalizing that stigma, lead to a negative illness identity. And that refers, according to Dr. Yanos, that a person is now taking a core part of their self-concept and identifying it with their illness. This can be both adaptive and maladaptive. What do I mean by that? Person can have a positive illness identity or a negative illness identity. A negative illness identity is where the individual's perception of themselves is dominated by thoughts of deficit, um, thoughts of inability, uh, incompetence, right? A sense of um, low self-esteem, low self-efficacy. And this can result in decreased motivation to pursue recovery goals, to take risks like going back to work, going to school, going and getting their apartment, right? Living independently. And so we see um, that we can play a huge part in addressing these concerns, right? Over the years, there has been an acknowledgement of this internalized stigma, systems effects, providers effects, contribute to the propagation of stigma and internalized stigma. And so we know that we can do things then to combat self-stigma, internalized stigma. First being taking more of a social model of disability approach. And this is a significant shift in understanding of disability, moving away from viewing it as an individual problem and looking at it as a societal issue, um, right? Societal barriers, environmental factors that contribute to disability. This model emphasizes that disability is not an inherent trait of the individual, but a result of the interaction between a person's condition and the disabling barriers created by society, right? And this model was developed in response to the limitations and stigmatizing nature of the medical model in a response to the civil rights movements in the 60s and 70s. It was Mike Oliver who was a key figure in the development of this model and argued that disability is caused by the way that society is organized rather than a person's condition or right their experience of a health issue. And according to this model, disability arises when society fails to accommodate the needs of the individual, thereby creating barriers to full participation in society. And so we see key principles of this model. We look at societal barriers, we look at inclusion and accessibility, we look at rights and empowerment. And this is really a social justice approach, right? Where we're looking to advocate for the removal of barriers, the promotion of equality, and inclusion. And that involves looking at policy change, public awareness, organizational awareness, and education, um, right? And this can certainly be complemented. I'm going to put this in the chat. Let's see if I can add this with the critical disability theory, right? That social model of disability goes hand in hand with the critical disability theory. And I'm putting into the chat a worksheet that helps you to conceptualize how to develop services with the critical disability theory. Go ahead and download that worksheet. This is going to hopefully help you to put into practice some of our key concepts today. So critical disability theory emerged in the late 20th century, gaining significant traction in the 90s. And this model infuses the social model of disability by providing a more comprehensive framework that examines power structure, cultural norms, social practices that contribute to marginalization and oppression of people with disabilities. And it was influenced by earlier work in disability studies, critical theory, and social justice movements. We think about key aspects of critical disability theory. It really focuses on intersectionality, the intersectionality of disability with other cultural identities such as race, gender, socioeconomic status, sectional identity, and it recognizes that individuals experience disability differently based on their unique social identities and contexts. Another key aspect of critical disability theory is the integration of functional and social aspects. And so when we think about CDT, it considers the functional implications of a health condition. It acknowledges that medical conditions can have real tangible effects on the individual that also need to be addressed alongside societal barriers. And it is definitely social justice based. It advocates for rights of individuals, of advocacy of individuals to address systemic inequality. Um, and there's also this critique of normativity, which we talked about earlier in the chat, right? Critical disability theory challenges normative assumptions about what is considered normal or healthy. It questions those societal standards that marginalize people with disabilities and seek to redefine disability as a natural part of human diversity. So when we think about what can we do, right? How are we addressing the concerns brought to our session today? First and foremost is reimagining our conception of disabilities using the social model and couple it with the critical disability theory. Another impactful way that we can move the needle, reduce stigma, is through our language. Language is a primary means of expressing our beliefs and our thoughts. And our words as a practitioner convey a message to the people that we work with. right? When we say low functioning, high functioning, too stressful, too symptomatic, not stable, suffers from, not capable, non-compliant, defiant, argumentative, right? These are terms that are conveying a message. And we could be potentially baiting people in language that creates illness identity, that creates stigma, or long-lasting identities of low self-efficacy. We want our verbiage to communicate connection and hope, right? We want our verbiage to translate that wellness, recovery, um, life goals are possible. We want to articulate that, solidify that through what we say, what we think, what we do. And some of these terms can be relics again of that medical model. We want to purge that from our nomenclature. We want to find verbiage that conveys hope, that conveys um, that disability, that critical disability theory. I'm seeing some things in the chat. Yeah, it, everyone is, when we think about our cultural responsiveness series, we're all on a learning journey. And so no worries. No worries. Take from today an assessment of what you want to keep and how you want to move forward, right, in your service provision. We are all in the role of student and learner. Um, and so hopefully we all can assess how we want to potentially fold some things in from our discussion today. You also want to think about, right, what can we do? We want to find ways to build a positive disability identity. And this refers to the way individuals with disabilities perceive and integrate their disability into their overall self-concept. It encompasses the recognition, acceptance, and incorporation of one's disability as a meaningful and valuable part of their identity. And this concept can be really crucial for understanding how individuals navigate, their world, their social world, advocate for rights, participate in society. Disability identity is shaped by personal experiences, societal attitudes, as well as cultural context. And we can do things to support those components of disability identity. One, so that self-acceptance, helping a person to recognize and accept um, a disability identity as um, a piece of diversity um, and a positive attribute, right? And this is hopefully involving moving beyond viewing disability in that medical model term, but instead, again, bracing it as a part of diversity and identity and a positive attribute, right? Second part or component of disability identity is community connection, helping a person to consider feeling a sense of belonging to a community of people with similar experiences. This connection can help to provide social support, shared understanding, and a collective voice, hopefully for advocacy or change and support. We also see disability identity developing when we help individuals get engaged in empowerment and advocacy, right? Engaging in self-advocacy, collective advocacy to challenge discrimination, promote accessibility, secure civil rights, equal rights, and opportunities, right? And that piece of empowerment also involves person recognizing strengths, capabilities, and using them to influence system change, which goes in hand with navigating the fourth component, navigating societal perceptions, right? Helping a person understand and manage societal attitudes, stereotypes for people with disabilities. And this involves resisting that internalized stigma, right? Denouncing it, challenging those societal misconceptions that devalue individuals with disabilities. And so there are all different ways through those four components so we can kind of help people to start to incorporate positive disability identity, one of strength, empowerment, connection. Phil Yanos, I talked about earlier, who is a second leading expert on this concept of internalized stigma, developed an intervention, the narrative enhancement and cognitive therapy for addressing internalized stigma. And this is a structured approach designed to help individuals with mental health conditions combat self-stigma. the key components of this intervention. And I believe he has a workbook available for purchase on this. But the key components of the narrative enhancement and cognitive therapy include psychoeducation, providing information about stigma and the effects on individuals and society, helping a person to understand that stigma is a social construct and not a reflection of personal worth. Then they have the second part, cognitive restructuring, identifying and challenging negative beliefs, thoughts related to self-stigma, and encouraging the development of alternative positive self-beliefs. Then the third piece of this intervention is narrative enhancement, where individuals are encouraged to share life stories, in supportive group format. And facilitators help individuals reframe their narratives, highlight strengths, achievements, or positive experiences. And then the final piece is skills training, enhancing the individual with their advocacy skills, assertiveness, problem solving. And it helps to boost confidence and reduce the impact of stigma on social interactions. I've worked with Phil, Dr. Yanos, using some of this intervention for a PTSD study. And we're now using it in a trans diagnostic study at Rutgers. And students have, this is in the context of students in post-secondary education. And people have in the study really reported positive impact of using this intervention. Not just in the domain of building a positive disability identity, but also in functional outcomes in their classwork, right? Their academic outcomes. And then we have another route or intervention to bolster, right, positive disability identity would be CBT, cognitive behavioral therapy. And this was developed by Aaron Beck, and it's a widely used evidence-based approach that aims to change patterns of thinking and behavior that are causing stress and those like intrusive, um, perpetuating thoughts. And it is particularly effective in addressing various aspects of mental health conditions, including the development of a positive disability identity. We can help the person to focus on relationships between thoughts, emotions, and behaviors, and reframe negative beliefs about mental health conditions, reduce internalized stigma, promote a more positive self-concept through that work. And we can do that with cognitive restructuring, right? Identifying and challenging those negative thoughts. Behavioral activation, encouraging engagement in meaningful activities that can enhance self-esteem. Skills training and self-monitoring can also be a part of that CBT process. Oh, I do see something in the chat. Yeah, I think that's a great point, Joseph. When we think about verbiage, um, everyone has a preferred terminology, and it can fall under oftentimes person first language or identity first language. So, person first language emphasizes the individual rather than the condition, right? And we see that a lot in psychiatric rehabilitation, where we would say person with schizophrenia, right? We would never say schizophrenic. That is antiquated, um, pejorative, that is um, stigmatizing, right? Whereas the identity first language, we see this in different disability communities. Um, Predominantly, what I'm thinking of is the community of individuals with autism. So, right, person first language would be individual with autism. And then identity first language, that person, right, ascribing to identity first language would say, I'm autistic, right? I am autistic. And so everyone has preferences in terms of language. Within our service provision, we may have to check in with folks and see what is their preferred verbiage. Do they prefer um, differently abled, right? Or do they prefer disabled? And so I really appreciate you bringing awareness to how do we engage in that verbiage and how can we make sure that we're honoring a person's preferences? And it's that simple check-in, right? What are the terms that you use? What feels good and right for you? How do you reference your mental health condition or your health condition so that we are mirroring those preferences? Great point. And then last but not least, as a way to build, right, to build positive disability identity, to build someone's self-efficacy, to reduce that internal stigma, that um, self-stigma. There is Wellness Recovery Action Plan, and this is an evidence-based um, intervention that is self-paced, and it is really a preventative wellness tool that anyone can use to explore wellness, build self-efficacy and empowerment, as well as hope. It was developed in the 90s by Mary Ellen Copeland, who is a mental health recovery advocate, author, educator, and a person who has lived experience. And she designed this tool. She was so tired. She was exhausted in terms of hearing people, practitioners, particularly prescribers, say, you'll be healthy when, you'll feel better when, right? You'll feel better when you have the right meds. You'll feel better when you have the right dose of meds. She knew medication was a part of her wellness toolbox, but she refused to believe that her wellness, right? Her day-to-day wellness was solely reliant on something in a jar, in a bottle. She wanted something that she could do, right? How can she influence her wellness? What can she do? Again, very um self that piece of self-determination, very empowerment focused, hope focused, right? Um, what can she do to support her wellness? And so she developed this tool that looks at one, what are the things that you do, right? Personal resources, activity, skills, strategies to use to maintain wellness and manage stress. And this list of things is called a wellness toolbox. That is the first core component of WRAP. Everybody develops a wellness toolbox, and that's what do you do on a daily, weekly, monthly basis to stay well? Maybe it's drink your water. Maybe it's take your medication. Maybe it's make sure that you get enough sleep, get some exercise. For me, I know on my wrap, I am needing to take my iron. If I'm not taking my iron supplement, I feel it, right? So wrap starts with the wellness toolbox, then it looks at a daily maintenance plan, right? A structured routine that helps you to stay well. Then it goes into triggers, right? There's a whole section on identifying triggers, external events, circumstances that might cause stress, discomfort, and then developing an action plan to address them. WRAP then moves into early warning signs, recognizing subtle signs that indicate that things are not going well, getting worse, and creating a plan to respond to them. And then finally, there's this piece of when things are breaking down, when you are not well, what do you look like? Who is that person? Right? And what are you doing to manage the situation? And then there's this last piece of if every effort to thwart a crisis was not successful, what's the crisis plan? Right? Creating a comprehensive plan for others to follow when the individual is really feeling overwhelmed, unwell, and needing higher level of care. What do they want to happen, right, when they're experiencing that crisis? Who's involved? Who's orchestrating support? What services do they want? What services do they not want, etc. And then a post-crisis plan would be completed in a wrap if that person were to experience a crisis. And so this is one of the most, I think, impactful tools that I've utilized both in my um, public mental health service provision, as well as my private practice. There are general wraps, wellness recovery action plans. There are wraps specific for students, for workers, and people just really engage with it because it, again, is very empowering. How do you keep yourself well? How do you avoid triggers? How do you bring yourself back to a sense of wellness if you are experiencing triggers or early warning signs? Um, it's one of my favorite evidence-based practices. But again, it helps people to build a positive disability identity because they're feeling empowered. They're building their self-efficacy and self-determination because this is all decided by them, right? With your help of facilitation. Okay, so for today, what did folks learn? What are you taking away from today? What are we taking away from today's session? Yeah, there is power in reclaiming identity. Yes, 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 yes. Anything that you are taking away from today's session. As you guys are putting that into the chat, I'm going to put the materials from today's session into the chat. Anything that you are taking away from today. Yeah, we can definitely look at future sessions on some of those interventions. All the ways discrimination happens, how to encounter it, how our service system can impact and perpetuate stigma. Wider perspective of stigma, language is powerful. Yeah. Also important how we use it with people, how far we've come on treating others without stigma, but how far my my mouse pad is like so sticky. My apologies. I can't get back to that comment. That we can advocate to destigmatize disability. Yep, critical disability theory, to keep that at the forefront. Amazing. Yeah, I love that you guys are. Oh, I am gonna, we're like almost out of time. So I want to make sure I put our survey for today's survey for today's session in the chat. But yeah, we covered a lot of ground in terms of looking at the experience of stigma and how that impacts a person on different levels, right? When they are experiencing that internalized stigma, the process of how stigma becomes internalized, and how service system providers inadvertently can be a part of how stigma is perpetuated, um, as well as the things that we can do to counteract some of that. All right, so I put into the chat the PowerPoint, and I need to see, put that link in. I'm going to put a link into our survey. So please